All right. And with that, we're going to fit two more rapid fire talks in before break. So buckle up. They're going to be short, but there will be coffee, I promise. Our first session is on designing for dyads. We're focusing all on building trials that are more equitable and meaningful and really include thinking about both the person that is pregnant and the effects that it might have on the fetus and eventually the child. And so the goals of this session are really to highlight some of the importance of having patient partnership in perinatal trials and some of the advantages and some of the reasons why we should all be doing this. We'll talk specifically about trials with pregnant people and trials with neonates and what are some of the specific considerations. What do we need to think about differently when we're doing trials with these populations? And we'll talk about developing some strategies for designing meaningful trials in the perinatal period. So I'm going to quickly introduce all of our speakers for this panel, as well as our wonderful moderator, and then I'm going to turn it over to Lori and Nawe for the first talk. So first, we're going to hear from Lori, as she has lived with juvenile rheumatoid arthritis since she was 14 years old, and this disease has impacted all aspects of her school, work, pregnancy, and parenting. Her lived experience has led to her involvement with the Canadian Arthritis Patient Alliance, a grassroots, patient-driven, and managed organization. And Nawe Moss, going to come up and speak with Lori, is a dedicated advocate for women's health and a friend I met on Twitter and invited to travel across the world. So thank you. Her collaborations with patients and clinicians and researchers and organizations have been really pivotal at a global stage in ensuring that patient perspectives help shape the research agenda. Then we're going to hear from our obstetric colleagues. So we're going to hear from Dr. Natalie Dayan, who's an assistant professor of medicine at McGill University and an attending physician at McGill University Health Center. We're going to hear from Dr. Isabelle Malhamé, who's a clinician scientist and assistant professor in the Department of Medicine as well at McGill University Health Center, and she specializes in obstetric medicine. We're going to hear, I think I skipped your bio, Shivik, but we're going to hear from Shivik Mitra, who is a neonatologist here in BC. Sorry, I'm going to blame the script for that, but feel free to add anything else to your introduction. And we're going to hear from Dr. Carl Halakard, who's a distinguished professor and neonatologist who's joining us from Belgium today. So I'm going to make sure my job is going to be to keep them on time. So if I stand up behind you, please wrap up. Chelsea will hold a sign that says you have 2 minutes. So we got lots to do. So then I'm going to turn it over to Fabiana. So Fabiana is going to moderate a panel. So please, if you do have questions, keep some notes. You will have time to ask them. It will be after the break. And so with that, I'm going to invite up Lori and Nawe to take it away.
Well, I will, yes, I am a little shorter. I will start things off and then I'll pass it over to Nawe for the last 10 minutes. Rapid fire will be. So I don't know if you want to introduce yourself now or.
Yeah, hello, I'm Nawe. So yeah, I'm also kind of like a patient voice person. I've come from the UK today. So I feel very honored to be here with you and with Lori today.
Yeah, thank you so much. Yeah, it's so funny. I mean, it's really nice to actually meet people like Lauren and Nawe because, you know, I've been trying like Nawe, but on the other side of the pond to kind of bring greater awareness of the experiences of pregnant people with chronic illnesses and disabilities for quite some time. So it's quite encouraging to actually be amongst all of you because I think you all sort of care to the same level as well. So in terms of a little bit about who I am. I mean, I have to mention CAPA or my role with CAPA because most of the work that I've done in this space has been sort of under the banner of that organization. And I'll give like a super brief description of the organization. You're more than free to sort of tweet about this on Twitter or X or whatever it's called now, as well as the CAPA account. So anyways, here are my disclosures for the presentation. So a little bit about CAPA. I mean, I sort of came across the organization in the mid 2000s, sort of amidst the withdrawal of an arthritis medication. And that's kind of how I became involved in this world. We kind of cover those three main points in terms of offering education and support. And I'm going to do a plug. I'm here and I've been pleased to work with Dr. Mary Davir and her team as we're offering 2 Café Scientifiques. One is happening happening this coming Sunday. If you are more than welcome to register and get involved and just hear from, parents as well as researchers, including one that's involved with Indigenous communities and involved with Impact, Ashley Hayward. So, but really here today, I'm bringing my perspective as someone that's lived with a chronic illness, a pediatric illness, sort of veering onto the rare disease space, diagnosed with juvenile rheumatoid arthritis in 1991, back when therapeutics were definitely not what they are today for arthritis. So I've kind of experienced the before and after. And so I've really relied on prescription medications for much of my life, right? At 14, I haven't really, I've actually taken therapeutics and medications more than I haven't. So it came as a real surprise to me as I, got older and was contemplating pregnancy and becoming a parent, that I found out in this pre-pregnancy counseling that all of the medications pretty much that I was taking had not been properly studied in pregnancy. I was just like, how is this possible? I was genuinely surprised, right? Despite, living with the condition at that point for close to 15 years. So yeah, it was a hard reality to sort of face that, those medications I couldn't take. And so I was often faced with well, what am I going to do? There's such a scarcity of evidence, and me and my husband had to make these very difficult choices around what to take and not to take. So much so that even, I just heard that, I would likely also possibly get worse. I might possibly get better as well during pregnancy. So there was a lot of uncertainty, and found out that I was more likely to flare sort of in the afterbirth. And so found out as well that I'd have to go back on those medications very, very quickly, right? If I wanted to be the parent that I wanted to be, or else I was basically faced with, living in pain and losing a great deal of my function. So it actually inspired me during that time to participate. Mother Risk was still going, a entity at the time. And so I gave a sample of my breast milk, to the organization to study. I never knew exactly what the results were at the end of the day, but I guess I just felt strongly about building that evidence base so that other parents or, parents to be would have a bit more data in order to make these very difficult choices around treatments. My son was born. That's my little Charlie there, my silly Charlie. And pretty much that picture reflects who he is today. He's a very happy and silly boy. Things didn't go as well for my second pregnancy. I seemed to be able to manage, though always sort of managing off the pain that I might experience and my symptoms. But things, and signs very early on were that this pregnancy was not at all going to be like the previous one. And so I ended up, having to go off my medications yet again because, faced with very little evidence around their use in pregnancy. And I'll be honest, that same medication I'm taking today, and I still don't really know whether it's safe to take during pregnancy. And so Charlie's 11 years old, right? So anyways, things weren't going well. I ended up having to go on increasing amount of steroids, like massive steroids, I have to say, by the end of by the time I entered my third trimester. And so I was admitted to hospital, I think 3 times. They couldn't quite figure out what was wrong because, of course, I was always taking medications to manage my condition, and these funny symptoms started coming out that no one could sort of put their finger on. And so it sort of culminated in the week before he was born, where I was getting increasingly more difficult to breathe. And the next thing I sort of had a crisis. I had a seizure, and that was my last memory, right? And then I woke up in the intensive care unit. Luckily, Charlie was okay. He was in the NICU, but found out he wasn't breathing when he was born. So that's hard, right? Just living through all this. So it's why I guess I feel so passionate about the topic and, why I'm here today. So I guess going back to some of my major challenges is it's really quite hard to make these decisions when it's for 2 people. Like I said, I was often managing the risk of the pain against the symptoms that I had. It was just a lot of uncoordinated care as well, and healthcare wasn't super accessible to us. And I'd like to highlight a recent report that I was also involved in recently, looking at equity, inclusion, and pregnancy care, which basically found, very similar issues, not just my own personal experience, but across a lot of people becoming pregnant in the province of Ontario. So, often I'd kind of go see my maternal fetal medicine specialist and I'd ask about my rheumatoid arthritis, for example, and they refer me to my rheumatologist, and then I'd ask my rheumatologist about the pregnancy and they'd refer me back. So just to give you like a very practical example as to how you have to manage care amongst all that. And also having to access allied healthcare professionals sort of on my own. Again, another healthcare provider to kind of get through and manage. So I guess all that being said, it sort of led me to work on developing some resources for pregnant people living with arthritis. These resources are available. And, I guess it's been really awesome to kind of meet, all these different people. I discovered and met another advocate based in the US called Mariah Leach. She'll be speaking at our parenting webinar on Saturday. So, encourage you to come see her. And she founded this group called Mamas Facing Forward. And it's a very positive Facebook community of, many parents that live with chronic illness and the different issues that they face. So we co-developed sort of the next version of these resources so they could be shared and used more broadly. I also launched, co-led anyways, the Bearing It All project, which I'll talk about in the next slide. And you can, again, go to that website to learn a little bit more about the project. So this was a collaboration amongst, I don't know if you can see the image, but, there's the Canadian Arthritis Patient Alliance, Canadian Spondylitis Association, Canadian Psoriasis Network, and Canadian Association of Psoriasis Patients. So we surveyed basically over 400 people that live with psoriatic, rheumatic, and inflammatory diseases. And so we had a very broad focus looking at sexual and reproductive health needs. We often kind of just focus on the pregnancy, for example, without understanding the obvious prerequisite to that. So, and we really just wanted to become more inclusive and kind of target a broader set of topics. So they basically identified that their health is impacted across all these different domains, right? Family planning, pregnancy, mental health, and perimenopause and menopause. And you can go to our website to learn a bit more. But again, like I was mentioning before, with finding other people as well. And, we found that, nearly 1 in 10 were actually trying to prevent pregnancy, but less than half had really had any, substantial conversations with their healthcare providers about the impact of their medications on their ability to conceive, right? So this is really big news, right? Like these are people that rely on medications like I did to manage their health, right? And I might also add that there are some clear teratogenic medications, right, for people, like I take one now, for example, now that I'm beyond having children, at this point with my 11-year-old. So, things like methotrexate and leflunomide, right, that have, very specific indications and use during pregnancy. So yeah, this is very bothersome from that perspective, as well as just some medications like those used for pain, non-steroidal anti-inflammatories, right, which are not supposed to be taken in the 3rd trimester, right, or else they can cause issues with the developing fetus or the baby. So yeah, this is pretty worrisome that this isn't happening sort of more broadly. And here are just some quotes in terms of what some of the people who took our survey said, right? That some had, found out that they may have miscarried due to taking one of the medications and one of those non-steroidal anti-inflammatories, for example, that they were told not to have children, right, by their healthcare providers. And because of their condition, or perhaps because of the medications they take, or just being, concerned about being a parent and feeling like they didn't have the resources to support, being the parents that they wanted to be. And so another sort of key finding of that survey was that, they actually hadn't talked to their providers about their medications until they were pregnant, right? So, and we know, right, that so many pregnancies are unplanned, right? This should not really be a surprise, right? Like, having children and these babies are, but there's a strong desire for information, right? I don't know, hopefully you can see the detail there, but the highest information need was around medications and how safe they are to use during pregnancy, during breastfeeding, right? And just advice on how to manage the impact of pain and how to manage the impact of fatigue on, during pregnancy as well as in the parenting period, and just advice on trying to be the parents that they wish to have. So all that being said, and looking ahead, I mean, I think NAWA is going to do like a super amazing job in sharing sort of more broadly some of the solutions here that need to happen. But I'd really like to see, I mean, I'm involved as a patient partner in research. And so I always ask, are pregnant people included, right? And it's always like, no, they're not actually. And we're just going to exclude them and make sure we clarify that in the protocol, right? I was like, that kind of wasn't what I was going for, but I like to see, that we actively include that community, right? That because there are real world impacts to not having that information. That if, people are deciding to keep taking these medications, we should be tracking every single one of them, right? Like, why do we not know? And that we also, it's like you make a lot of hard choices, right? At least like follow them. And also just to have person-centered multidisciplinary counseling, and of course to involve patients and people with lived experience in developing all the solutions. And just a few upcoming events, like I said, that parenting webinar on the right, if you want to scan the QR code, but also because of some of this other work I've been doing in the province of Ontario, we're holding a webinar with ICES on June 18th, where you'll get to hear from me, the researchers, and other people that live with disabilities that have been pregnant or are parents, as well as I think the ADM of accessibility in the province of Ontario. So, we're trying to do our best, I guess, to raise awareness of some of these issues and to get some change. So with that, I will pass it over to Nawa.
Hi, hello. Yeah, that was so moving. Seriously, so moving. I don't have a disclosure slide, but I just, before I start, I'll just say I do some work on patient public involvement for the University of Birmingham and Queen Mary University of London. And I have a tiny little charity. And a lot of the work that I'm going to talk to you today about the Brid Commission, I actually do unpaid, just because, like Laurie, it means so much to us. So I also have a chronic condition, and I was very lucky because I also had preconception counseling before I got pregnant with my first child. And I was incredibly lucky because there was a trial going on, a randomized control trial, and I decided to take part. For me, it was more or less that I wanted more care, closer care, which is one of the reasons why I took part in the trial. And then when I had my second child, so I learned a lot through that because it meant that I learned more about my condition, more about pregnancy and managing my condition in pregnancy. And when I went to have my second child, that meant that I knew a bit more about this. And I had my baby in a different hospital, in a smaller hospital with different level of care. And it made me really angry because my care was not great. And and it's only because I'd had my first baby through this trial that I actually knew what I should be expecting and the things that I should be looking out for much more than my healthcare provider. So I think that's one of the reasons as well why I've been advocating. And similar to Laurie, this is actually a really stressful, anxious time for you. Like it really, really is. And just to kind of reiterate what Laurie said is that, we have to live with the decisions that we take during pregnancy about our medication, for the rest of our lives. This isn't just, we can go home at the end of the day. This is years and years. So my child had a congenital anomaly and, he's fine. It's all fine. But, it's been lots of years of going in and out. He's had a relapse and he had an operation earlier this year. And this is, again, 11 years old, So those kind of consequences last a long time. And you carry that guilt. A lot of the time you do carry that guilt. So one thing that's sort of obvious, probably to many of you, is that these problems aren't just, you know, for Laurie or I in one country or another country. These problems and issues and anxieties span across the world. There's millions and millions of women having babies, or wanting to have babies, that are facing those same challenges. Should I be taking my medication? Can I get pregnant? Should I be breastfeeding? So yeah, so the burden is really compounded as well, is if you have more than one condition. So there's many women who have multiple health conditions as well. And this commission, the Bridge Commission, it's one of many initiatives globally, but we came together. It's a group, a multidisciplinary group of sort of experts in pregnancy and breastfeeding. They include researchers, health professionals, former regulators, patients and advocates. And we all do this voluntarily, and we are all over the world. So we represent different health systems in different countries, and we all have a common goal, really, which is around elevating women to be guardians of their own health alongside their health professionals, and making sure that women have, and families have, access to reliable, high quality data to help them understand the benefits as well as the risks of disease management. So there's lots of stats here. I'm going to refer you to a report shortly, but I just wanted to reiterate, there's no easy answers. These anxieties and these questions that we have, it's difficult. And we're often left to do this with little or no data and very little understanding about the benefits and risks of stopping medication or continuing. So we just recently published this report. So I have it over here. So it literally came out a couple of weeks ago that the Commission's been working on. And in essence, we tried to think about some of the practical action-oriented solutions. So yesterday I was in one of these meetings, and Christine was saying about, you have to think big, but actually you often have to start small. So some of these things are just small things that we can take away with us. And we realized that, it's an ecosystem. There's lots of different stakeholders. And we wanted to make sure that we had options and recommendations for different stakeholders within this. So we split the report. There's a couple of sections. So one is around data generation and making sure that women have opportunities to take part in research during pregnancy and breastfeeding, because at the moment there's a gap, and that gap, it makes it really difficult to weigh up the risk of continuing or stopping medication and enabling us to make decisions. And not just us, but even our healthcare providers. Because even if we look to our healthcare providers, as much as they try, they don't know, because the data is not out there. The information, the evidence isn't out there. So there's lots of recommendations. I know it's a bit small, and you can have a look. I've got some copies of the report, or you can scan at the top on the QR code. But one of the items is around including pregnant women and breastfeeding women in clinical research. This should be standard practice, At the moment, often they're either excluded, or if women become pregnant during a trial, their data is excluded. So we really need to make sure that this is the default position. And if we are excluding women, then what is the rationale for excluding them? We need to invest in long-term data collection. I think Alicia mentioned around this earlier on. A lot of our anxieties are around the impact for our children. So being able to have a longer term evidence base is really important. We're also thinking about underserved populations and how we proactively include them in clinical trials as well, and that the research is representative. And research dissemination. So this is a bit of a pet hate of mine, because often I used to assess funding applications in the UK for the big funder, and often all our funding applications, everyone is focused on doing the research, which is great. But at the end of the day, you need to be able to share your findings so that this actually filters down into how care happens for patients. So we put something in there around dissemination and making sure that that's integral. thinking about not like you guys are working on clinical studies during pregnancy and for pediatric studies, but actually there's lots of studies going on for chronic diseases, and those studies should include pregnant women, and regardless of what time they are through their pregnancy. And thinking about different trimesters, when we're doing clinical trials, we need to capture that information at the different trimester point. I think you mentioned about some medications, it changes during the point of pregnancy, so that's a really important item we wanted to flag. Other things, just more general, from a healthcare provider perspective, we need to make sure that there's opportunities for women to take part in studies, and we need to make sure that our health professionals are aware that the studies are happening, because if they're not aware, they can't put them forward for women to take part, and women will not have the opportunity to say, yeah, I do want to take part in that study or not. And also health professionals need to make space and time to have open discussions, because often you are reluctant to take part in a study. It can be quite a big daunting thing. And during this report, I mean, I've spoken to many women, a bit like Laurie, but during this report we also spoke to 13 women in lots of different countries. We had a lady in Canada, but everything from Indonesia, Italy, Peru, and they had different chronic diseases. Some had multiples, and they came, they often said very similar things, and we tried to integrate their voices into the report. But one thing that I thought was really important is that everyone has different comfort levels. So not everyone is going to be happy to take part in a clinical study, but they might be happy to take part in research. And that's a starting point. And we still need to be able for them to have opportunities. And even if they take part one time, maybe sharing their data, they might be more open for another time to take part in a clinical trial. Okay, I'm going to move quickly. So access to information, we have another section on this. One of the main things is around not overstating the risks, but also making sure we communicate the benefits as well of treatment. And I mentioned about dissemination, making sure that study findings are spread widely, and making sure that, from a capacity building, I wanted to say, actually, this is so important, the work you're doing here. We have said something about this, is the training component is so important, because if we don't have people like you, then we're never going to, close the information gap. So I think I will, just before I wrap up, one of the things we're asking for in this report is that we really need a paradigm shift in our way of thinking, and from, fear and protection. I think Alicia mentioned this earlier on, thinking about security and empowering. So thank you so much. Yeah. And it's lovely to be here. And yeah.